We have Dr. Mira Keddis. She is a nephrologist and assistant professor of medicine. And she did her medical training, I think your entire medical training at Mayo Clinic. You've been a Mayo lifer, I believe, right? Starting with med school, residency, chief residency, and fellowship. So she's going to give us a great talk on chronic kidney disease, what primary care providers need to know. Thank you.
Good morning, everyone. Thanks for being here. I'm delighted to take you on a journey of a typical clinic day with me. And hopefully there'll be some pearls that you'll go home with that will be applicable for your practice. I have no disclosures, and these are the objectives for our talk today. I want to give you a little bit of a flavor of what's happening in the nephrology community about controversy about how we diagnose kidney disease. I want to walk you through some approaches to diagnosing chronic kidney disease. We'll go through some cases. We'll talk about risk factors and complications. Why do we worry about kidney disease in general? And then I want to introduce you to an equation that came about a few years now. It's called the kidney failure risk equation. And I think it's really a nice tool that can leverage some of the patient's fears and expectations when you see them in the office. So what is chronic kidney disease? We call it a disease, but it's not really a disease, it's a syndrome. And by definition, it can be a change in the kidney structure, or it could be a functional change. Examples of a functional change would be things like liver disease or cardiorenal syndrome. Oftentimes, the kidney structure itself is actually normal, but it's a hemodynamic effect. So it's more of a functional change that is reflected by a low GFR or an increase in creatinine. So you either have a kidney structural change, which you typically can detect that based on a urine study when there's abnormal microscopy or proteinuria, or it's really purely a change in GFR. And by definition, you really have to see this change persistent for at least 3 months to call it quote-unquote chronic. Kidney disease is quite common. In the United States, as you see, it's about 6.7%. A little bit more in South America and Southeast Asia, and there are a lot of different risk factors that contribute to that in these different regions of the world. I think this is an important slide that I hope you become familiar with. This is really our guideline of how we characterize kidney disease in terms of severity and what we look for. And I think one of the key things that came in 2013 is to really include proteinuria, albumin to creatinine ratio, just based on a spot urine in your way of assessing, is this someone that you should worry about having kidney disease or not? So I'm going to walk you through it here a little bit quickly. G1 is essentially stage 1 kidney disease, which we oftentimes, you almost never see anymore in any of your patients. But I want to point out to you that if this person who has a GFR more than 90, so for all intensive purposes, they have a creatinine of 0.7 or 0.8, but you do a UA, let's say they're diabetic, and they've got albumin to creatinine ratio greater than 300, that's someone on risk. And it's actually quite a common phenomena that we see that a diabetic patient, they go through a stage of what we call hyperfiltration. So when there's prolonged exposure to increased glucose or hyperglycemia, what happens is there's hypertension in the kidney, and this hypertension leads to leaking of protein. The filter becomes very leaky, and before we see any change in GFR, we start seeing changes in the urine. So this is a patient I would not consider having normal kidney function. This is someone I would watch very carefully, and oftentimes our diabetics are doing this. Their GFR goes off, up, and then they fall off the cliff. And then when they fall, it's pretty rapid in terms of the deterioration that you see in their GFR. Mildly decreased is between 60 to 89. Again, the same concept. It may look good, but if they have proteinuria, I worry about them. If they have no proteinuria, I don't worry about those patients. In fact, oftentimes, if I don't identify risk factors, I say, your kidney's fine. You're going to be okay. And I leverage that, obviously, with their age and comorbidities, and we'll go through some cases later. G3A and G3B is stage 3A and B. This is what we often see, at least coming to our clinic. And that's when your GFR drops 45 to 59. That's when we classically see that red flag in your lab. You know, the GFR drop below 60, there's something else going on. And the same applies. You have to worry about, do they have proteinuria or not? Stage 4, these folks should always be in the nephrology at that stage. You really need to be referring them to us once they drop below 30. And that's because we're talking about dialysis planning, we're talking about transplant referral. These are the folks that are at risk of progression to end stage. And obviously less than 15 are the folks that are heading or on dialysis already. So let's think about a normal kidney. So a kidney is just like any other part of our body. It gets old, it shrivels up, it shrinks, it wrinkles. And so it's normal for a kidney function to change, to drop with aging alone. In a healthy cohort of patients who are older than 70 years, doing kidney biopsies on them showed that there's 73% scar. That's a substantial amount of scar. And this is from aging alone. This is not because they've got hypertension and diabetes and all of these other comorbidities. Versus if you have a 29-year-old or less than 29-year-olds, you expect a much smaller degree of scar. Kidney volume changes. If you do renal ultrasound, it's okay for an older individual to have a kidney size that's maybe 10 to 11 centimeters versus a robust young person, you know, I would expect around 13 centimeters in terms of a kidney size on a renal ultrasound. And this is, I think, what's so important. I'd like you to think about that is per decade of life after you hit age 40. So from a kidney standpoint, you're old after 40, which is a little intimidating. But once you hit 40, every decade of life, you lose 7.5 mLs per minute of GFR from aging alone, okay? So you can average that to about 0.7 mLs per minute, almost 1 mL per minute from aging alone after age 40. So keep that in mind as you look at GFRs in patients and how that changes over time. And this slide is just to show you that we're all born with a certain amount of nephrons. We call it the nephron endowment. And that has to do with maternal risk factors, your birth weight, and you're born with a certain number. And this is what you're stuck with. And if you're going through the same trajectory of losing 7.5 per decade, if you're born with a small amount, you know, you're going to lose a lot more later in life, and it would put you in that GFR of less than 60, give you CKD stage, essentially CKD stage 3, even though maybe you really are otherwise a healthy individual. This is another slide to just show you that when we think about the spectrum of age and how we currently define CKD, which is essentially a GFR less than 60, if you are healthy, you could meet that criteria just from aging alone, and we're seeing more and more patients in the 80s and the 90s. If you're old but you've got comorbidities, we see them meeting that diagnosis a little bit earlier, and clearly if they have another reason, a primary reason for kidney disease, you hit that definition a lot earlier in age. So be suspicious about someone who's older, who is given a new diagnosis of CKD, whether it truly is CKD or it's healthy aging. So what to do with all this information? I tried to summarize that in 3 points. So if you have a healthy individual, they don't have your classic comorbidities, they have a GFR more than 45, so that's essentially what we call the CKD stage, GA. They may not need any further workup. You may say, don't worry, you're going to be okay. You're not going to die from your kidney, and I'll walk you through some of the equations that can help provide some of that reassurance. And you really don't need to worry about their kidney long term. You have to be mindful that every time you see a red flag that a GFR is less than 60 doesn't necessarily mean that the patient has kidney disease. So put it in the context of the whole patient, right? And then if you don't have proteinuria, and I keep emphasizing that, before I give somebody false reassurance, I always do a UA. I always do an albumin to creatinine ratio, because I know that gives me that's a strong risk factor. It's as important as what my creatinine is telling me, if not more important. So if you have no proteinuria, and your GFR is more than 45, and you're an older individual, more than 65 years of age, your chances of dying because of any complication related to the kidney is extremely low. So those patients don't have to carry the burden, whether it be mental or physical burden, of having a diagnosis of chronic kidney disease that could hurt them long term. So let's walk through one of the patients I saw about a year ago or so. He was a 49-year-old Bulgarian gentleman, had some psoriasis, a herniated lumbar disc, really none of your classic risk factors that we think about. And he was referred to me, but his creatinine was 1.5. He did have some NSAID exposure, but not on a regular basis. He's been told that his blood pressure tends to be high in the offices, but has been always within normal limits at home. And really his meds are nothing to be concerned about. You see him, his blood pressure is a little bit borderline. He's a big guy, BMI of 30. Creatinine was 1.3, he went to 1.5. 3 months later, it was 1.5, and his electrolytes were perfectly normal. And we looked at the urine, and 0.06 is essentially normal, no protein creatinine, no abnormality in his urine. So my question to you, do you think this patient has chronic kidney disease? He's 49 years old, or 59 years old. I would agree with the 70% in the crowd. I don't think so, but I want to confirm. So I do the eyeball test. So this guy walks in, he's tall, he's big. He's not your typical patient that walks into your kidney clinic. So I'm already biased. I think this guy's got too much muscles on him, that maybe this creatinine is not really true reflection of kidney disease. So the second thing, I probed for risk factors, and I didn't hear anything. I'm not hearing long-standing history of hypertension, difficult to control diabetes, none of the classic things. And the next thing I look for is, okay, how has it changed over time? Is there a trend? And I think that you need to keep in mind is, for a change to be what we would call statistically significant, meaning that it's a true change rather than a variability in lab, you want to look at a value that's 0.3 milligrams per deciliters or more. This guy had a creatinine of 1.3, went up to 1.5, so not really quite a change that would make me concerned that this is a true progressive change in his GFR. And then I repeat, is this what I'm seeing, is this real or is this a fluke? And then I look at the protein, make sure there's nothing there. And then after I do all this, I have to confirm. I want to convince myself, yes, this person really does not have kidney disease. So what would you do for this patient? How would you go about moving to the next step? Okay, so we did repeat it. Remember, we checked it, we repeated it 3 months ago. At this point, what I would have, well, at least what I did, what I encourage you to consider doing is actually looking at something called cystatin C. And let me talk to you about it a little bit. So his cystatin C, which is a number that you can look at just like you would look at creatinine, okay? His was 0.66. It's almost like he has a creatinine of 0.66. This is an equation that, or an app that, not an app, a website that you can all access online. It's free. Maybe add it as your favorites. It's called mdrd.com. What I like about this is because it gives me a better feel of someone's GFR if I have a cystatin C value. So one of the downfalls of our current labs is that when you get a GFR, this GFR that's almost all the labs in the United States is based on an equation called MDRD equation. Okay? MDRD equation is very old. It was validated only in patients with kidney disease. So it's not very generalizable to someone who doesn't have kidney disease. And we've learned that it can actually underestimate someone's true function by as much as 25%. So it's not a very reliable equation when you're dealing with someone who's really at the edge of even being diagnosed with kidney disease, right? That stage 3A, that GFR between 45 to 59. Is that even real decline in GFR, or does he have kidney disease, or is this actually normal? So this is one of the downfalls of the GFRs that are currently reported. In 2009, we came up with a better equation, which still does a better job, but still there's some underestimation. And in 2012 is really the new stuff, all right? So 2012, we have the cystatin C, and we have this combined creatinine and cystatin C equation. So you plug in a creatinine, you plug in a cystatin C, you put the age, his race, and his gender, and this is what you see. So looking at this, knowing what I know about this guy based on seeing him and assessing for risk factors, this guy really can donate a kidney if he wants. He's got a GFR of 120. And I rely on the CKD epicystatin C here because of of really a main thing. He was a big guy. He was a muscular guy. So this is what we need to know, what you need to know about cystatin C in general. So it's a molecule that's produced by every nucleated cell in your body at a constant rate. And the inverse of it is what you can estimate based on GFR. So if you don't have a computer or access to an Internet Explorer, just get out your calculator and divide, 1 divided by 0.66, and that'll give you an idea of what GFR is based on cystatin C. And that's actually a similar relationship with creatinine as well. It's the inverse relationship. So the key thing about cystatin C, it's not affected by muscle mass, and it's not affected by nutrition, like people who are on high protein intake. Reflecting back on Dr. Whitaker's talk, for example, oftentimes I see folks on testosterone replacements with a high creatinine. Why? They tend to have a little bit more muscle mass. And so I go to my cystatin C to give me some peace of mind about what their true GFR is. Remember that this equation is still an estimate. This is still not a true measure of your function, but it does a pretty good job when it's correlated with a true measure of GFR. When should you consider using it? If you have somebody who's morbidly obese, somebody who looks more muscular than your average patient, elderly folks, and especially folks who are malnourished. Sometimes creatinine can deceive you. It looks beautiful, but this person has really bad kidney disease. And the problem is you lose all that muscle mass, and creatinine is falsely telling you that someone's GFR is good. So it really, at the extremes of weight and with muscle mass, think about cystatin C as an alternate biomarker that's not impacted by that. So take-home points before you call someone, before you make a diagnosis of CKD to a patient. Remember to look for a trend, repeat it right away, and then check your urine and rule out any proteinuria. And if they're low risk, then you got to question, is this GFR even accurate? And then consider doing a cystatin C. And remember that the GFR that's provided to you in the lab can underestimate true measurement of function by as much as 25% in healthy individuals. Get a cystatin C when appropriate, but also a caveat here is cystatin C is still not perfect, right? Because there's still an estimate. It's not a true measure of function. And there are other things that can impact cystatin C. Atherosclerosis, believe it or not, a systemic inflammation, people on prednisone, cystatin C doesn't seem to do as well in terms of predicting GFR, and people with thyroid dysregulation. The MDRD.com is a really good tool for you to make sense of what the cystatin C means in terms of estimating GFR. At Mayo, we're lucky that we have a measure of GFR called iothalamate clearance test. Few institutions have that around the nation. Essentially, what it is injecting a substance. It's actually a dye-like substance, kind of like we use in radiology, and they have you wait about an hour or two, and then they measure it in the urine. So this is, by definition, is the gold standard of knowing someone's true GFR. How well do they clear a substance? So if you are in a facility that offers that, you can always consider getting the gold standard, which gives you with really 99% certainty what that person's GFR is. And this guy, I didn't even refer him that. I felt pretty confident based on his assessment and based on his cystatin C that he really does not have kidney disease. So how do you think through the risk factors for kidney disease? And I'm sure you recognize most of these things, but diabetes and hypertension are common. Obesity alone is a risk factor for kidney disease. Oftentimes we forget about our elderly folks and their frequency of urination. So obstructive uropathy is a real problem, and it's something we should have in the back of our head as we probe for and evaluate for kidney disease. Obviously, if they have a family history of a familial disease that causes kidney disease, like polycystic disease, Alport's or Fabry's, that obviously puts them at risk. And there are some genetic and racial differences. African Americans tend to have more kidney disease than non-African Americans, and we're learning more and more about unique genetic mutations that are present among African Americans that predispose them to specific kinds of kidney disease, like FSGS, for example. Prolonged exposure to nephrotoxins, and this one always catches us by surprise. They don't have anything else about, boy, I've been on, Celebrex for years. I've been on some form of NSAIDs for years, and all of a sudden you're dealing with someone with kidney disease. And not everybody who's on NSAIDs gets kidney disease, but it's something that we see often. PPIs have definitely got bad rep over the last few years because of some large studies in JAMA and some other renal journals showing that prolonged exposure of PPI, not H2 blockers, but PPI, any kind of PPI, is associated with having chronic kidney disease. Agricultural chemicals, maybe in other countries, or people have been exposed to, or we've grown up in other countries, something to think or probe for. Iron, mercury, all these things can cause renal injury. Chronic inflammation, obviously, with autoimmune diseases. And I always say that the kidneys are a very sacrificial organ, right? They give until they can't give anymore. They support every other organ in your body, but they're not very forgiving. So if they get an insult, you know, there'll be some leftover damage. So recurrent and severe episodes of kidney insults alone can predispose you to chronic kidney disease later in life. And the low birth weight is that concept that I brought to you, this idea of being endowed. You're given a certain number of nephrons at birth. And if you have low birth weight or there's some maternal risk factors, you may be born with a lower number that gets you to kidney disease earlier in life, independent of any of the other risk factors. So with that, we'll move on to the complications of CKD, which I'm sure you're all very familiar with. And so this is going to be just really some pearls and nuggets. I called it ABCs, but there's more to it than that, but I tried to simplify it. So we'll go through the anemia, acidosis, B for bones, really referencing phosphorus and PTH and blood pressure, C for cardiovascular risk, D for dialysis planning, E, electrolytes, mainly potassium, F for function, looking at the GFR itself, and then I couldn't fit the alphabet, so I skipped to U. So U is your uric acid. So when you think about anemia, I think the first thing to think about is you got to remember everything else that causes anemia in a normal person before you blame it on due to chronic kidney disease alone. So the first step usually is rule out the other stuff, right? Folate deficiency, B12. And then the big one that we see often in our CKD population is iron deficiency. And it's the really reason for it is multifactorial, but oftentimes it's a functional iron deficiency. It's a problem with a milieu that's inflammatory from having kidney disease that really causes your body to have difficulty utilizing iron stores. So the way we define iron deficiency is a little bit tricky in kidney disease. It's, again, not different than the general population. We look for a ferritin less than 500, and we really focus on a percent saturation that's less than 30. So if someone's percent saturation is less than 30 and their ferritin is not 500 or 600, then we would treat them with iron infusions or iron supplements. And we want to keep the hemoglobin between 10 and 11. Well, why not 12? Why not 13? Well, because there have been a lot of studies showing that if you really try to push the hemoglobin to quasi-normal, there's actually higher risk of cardiovascular morbidity, higher risk of stroke, and even in one of the studies, there was progression in kidney disease if you tried to give them too much EPA or try to drive that hemoglobin to normal. And that's why we have this small, narrow window. We also know that if their hemoglobin drops less than 10, they're at high risk of running into transfusions. So it's a very fine balance on both ends. Acidosis. So the reason I have a picture of a hamburger, not because I care for it, but animal protein generates a lot of acid in your body. Animal protein generates a lot of acid, and your kidney is the most important organ that gets rid of acid in your body. And when you have chronic kidney disease, boy, that takes a lot of energy to remove all the excess acid. So acidosis is common, and unfortunately, it's not good for you. There's increased risk of progression of CKD among those who have acidosis or acidemia, and there's high risk of mortality. And there's actually been data supporting that if you correct the acidosis with something like sodium bicarbonate, you can slow the CKD progression, you can improve bone health, and you can actually improve overall nutritional status. So I usually tell my patients, especially when they're in that CKD stage 3B or 4 or 5, try to go vegan or vegetarian a couple of times a week if you can. Cut back on your animal-based protein because that's an added stress to the kidney. The other B is for bone mineral disorder, and there's a lot of players in this. It's a very dynamic process, but what I'd like to drive home to you is that the first abnormality that you'll see is a PTH will go up. If your PTH is up, you've got a GFR less than 60, and someone's calcium is, normal to low, you can blame it on secondary hyperparathyroidism from chronic kidney disease, and you really don't need to do anything further. If you have a high PTH and a high calcium in somebody with a GFR of 30 or 40, they could have a primary hyperparathyroidism. We've seen that's unusual, but the trick is to look at what the calcium is doing. And the idea here is what happens is your PTH is one of the first things that goes up as your GFR drops, okay? And then the first thing, actually, vitamin D comes down. Vitamin D drops, then PTH, and the last thing that you'll ever see in the blood work being abnormal from kidney disease is a high phosphorus, okay? So we correct the vitamin D, keep an eye on the PTH, and then we really try to watch that phosphorus and correct it. So if you have a low normal calcium, a high PTH, and a GFR less than 60, you can call it secondary hyperparathyroidism with confidence, and we leave it alone. It's okay for a PTH to be up to 3 times the upper limit of normal. We don't get too excited about that. We just watch it and we look for trend. If you have someone who has elevated calcium plus a high PTH, and they're not on dialysis, for example, think about primary hyperparathyroidism. Tertiary hyperparathyroidism is a very unique diagnosis. I've really personally only seen it in people who are on dialysis. That's when they have hyperplasia or hypertrophy of their parathyroid glands, and that's really a late manifestation. You wouldn't see it in just a CKD patient who's not on dialysis. And really the approach is, again, cut back on your animal protein, lower the phosphorus. So what do we do in the clinic? If I have a CKD patient, I always check a vitamin D level. I try to keep that level more than 30. I tell them, hey, cut back on the animal protein, cut back on the phosphorus from animal protein, which usually comes in things like dairy. A lot of your chickens and meats are preserved with sodium phosphates. All that can drive the phosphorus in your body. When the phosphorus starts going up, I use a phosphate binder to bring it down. If my PTH is climbing, you can use an activated vitamin D, like a 125 vitamin D, like calcitriol, for example, that will help bring it down. And really, last resort is something like cinacalcet, and cinacalcet can really drop your PTH down to nothing. And we use that, we really reserve that as a last resort because it can also cause hypocalcemia and other issues. And the other thing I just want to briefly mention is that there's a balance between a too high PTH and a normal PTH. It's actually not normal to have a normal PTH if you have kidney disease, okay? Because we know PTH goes up. And we don't want to drive that PTH to normal because it can cause an entity called adynamic bone disease, which again causes brittle bones. B is for blood pressure. I'm not going to, this is a whole topic of its own, but for the purpose of this talk, we try to keep it less than 130/80. Remember volume expansion, okay? If you've got CKD, 90% of your blood pressure is from volume expansion, salt retention. So it's important to restrict salt and use diuretics, and use the diuretics liberally. I was taught in med school that every drug has to be adjusted down when you have kidney disease except diuretics. It's the only thing you increase the dose on when somebody has kidney disease. And you can consider some combination diuretics. You can even put a loop and a thiazide together if you have somebody with resistant hypertension. Cardiovascular, as you know, that's the most common cause of death in CKD. It's also the most common cause of death in dialysis patients. The lower your GFR, your higher rate of cardiovascular events. And if you look at our group on dialysis, 60% of them are going to die from a cardiovascular event. They don't live long enough to die from malignancies or other causes. Potassium, I'm going a little bit fast because I see I'm running a little bit out of time. But as you know, potassium is important for maintaining the electrochemical gradient in your heart. So how do you approach it if you have somebody with hyperkalemia? The first thing I would do is correct acidosis. If you correct the acidosis, potassium typically gets better. Think about your loop diuretics. Valtessa is a new drug that's FDA approved for management of hyperkalemia in CKD patients. It's a good drug, but it's very expensive, so keep that in mind. Hyperuricemia is common. It's actually bad for you, again, associated with progression in CKD. And there are some small trials that say even if you have no gout, and even if that uric acid is not bothering you, if you have a level that's more than 9, maybe you should treat it. And treating can actually potentially slow down progression in kidney disease. And these are the drugs that you can consider using. So I'm going to skip the take-home points. This is in your pamphlet. And I want to go into our next case. So TM is a 73-year-old guy, has hypertension, diabetes, BPH, used to use NSAIDs up until the day I saw him, actually, and was referred to me because he had a GFR 3BA1. So he had low-grade proteinuria, less than 30, but he was about a GFR of 30, and he came to me because of difficult-to-control hypertension. He was on clonidine, doxazosin, lisinopril, metoprolol, and furosemide. Blood pressure was high, and he definitely had edema on exams. He's anemic, mild hyperkalemia, a little acidotic. Phosphorus was a little high. Uric acid was crazy high. PTH was 100, which is really acceptable. And you've got a kappa to lambda ratio of 2.38, which was above this reference range. So what's the next step in evaluating his anemia, you think? He had a hemoglobin of 11. Excellent. All right, so I'm going to skip that slide. So exactly, always look for iron deficiency first before you move on to any other steps. What's the best next step in managing his hypertension? Wonderful. That just makes me proud. So the more severe the kidney disease, the higher the dose. So don't be timid. You know, I have a guy in the hospital right now with 400 milligrams of IV Lasix, and he's barely peeing. So it's okay to be aggressive with diuretics. And these are just ideas. I'm not saying everybody needs these doses, but this is something you should be thinking about. If you're between 30 to 45 mLs per minute, this is an appropriate dose of Lasix, 40 milligrams twice a day. It's better to have it in divided doses. If you're less than 30, it's not uncommon for us to drive them as high as 100 BID of furosemide. You need more to get the edema controlled, to get the hyperkalemia controlled, and to get the blood pressure controlled. So you notice his kappa and lambda are high. What's your next step? What are you going to do? His ratio is above the reference range. He had no monoclonal protein, but his ratio is above the reference range. This one tends to be a tricky one. So hopefully I will reveal the truth. So free light chains are cleared by the kidney. That's the normal process. And when you have a plasma cell dyscrasia, usually the plasma cell makes one or the other. So the ratio becomes off, right? So typically if you have multiple myeloma or you're worried about it, either the kappa will be higher or the lambda will be higher. But no, not both. Both will not be equally high at the same time. And that's why you look at that ratio, right? Now, there have been a few studies to look at, well, how do we interpret ratio in somebody who has CKD? And it turns out that you really have to think about a wider reference range. And it's okay, this gentleman, for example, in the absence of a monoclonal protein and his level at 2.38, even though it exceeded my lab's reference range, I wait until it's above 3 before I really get concerned. So just remember that the reference range can be widened in somebody who has CKD because these are cleared by the kidney, okay? And it has to do with the size of kappa with respect to lambda as well. I'm gonna skip the take-home points because I really don't wanna miss out on the tale of two patients here. So I have an 80-year-old who came to me for referral for chronic kidney disease, creatinine of 1.3 for 2 years, so really stable, no proteinuria, but it has creatinine of 1.3 at 80, okay? Then I also have a 54-year-old with IgA nephropathy, hypertension, cirrhosis. He's not doing so hot. Creatinine of 3 for 3 months, and he's got about 2 grams of protein. So this is the other equation I want to introduce you to. It's called kidneyfailurerisk.com. It's, again, available to you, and it's really been very powerful for patients to see numbers. So for this patient, I plugged in her numbers. She's 80 years old. She's a woman. She has a GFR of 39. That's what you would call CKD stage 3B. And she has no proteinuria. I tell her, you're 80 years old. Your chance of losing your kidney at 2 years is almost 0. Your chance of losing your kidney at 5 years is not even 1%. And then they just have that sigh of relief. Oh, okay, then I don't have to worry about my kidney disease. This is a patient who's not going to die from their kidney disease, okay? My other guy, I say, hey, I plugged in your numbers, you're 54, it's putting you at 3%, so you may not end up in dialysis in 2 years, but boy, you are at risk at 5 years, and this is what we call intermediate risk, between 5 to 15%. So I tell him, we need to get you taken care of. We need to see you soon. We need to make sure we get our risks modified as best as we can, because he's in trouble. So this is a kidneyfailurerisk.com. It was made in Canada, but validated in almost every other continent across the world. It's a really helpful tool to leverage their expectation and their fears about this new diagnosis of chronic kidney disease. The thing that you have to be cognizant about is it assumes all things are constant. So if my poor 80-year-old ends up with perforated diverticulitis and emergent surgery, she'll go into AKI absolutely, and that will have an impact on her GFR. So it doesn't take into account the unexpected. Okay, it assumes things are healthy and constant. All right, so I hope over this last 30, maybe 5 minutes, we went over some of the controversy about CKD in the elderly, when you should worry, when you shouldn't worry, what aging does to kidney disease or kidneys in general. Think about cystatin C and when to utilize it. Just remember the different complications that come with CKD, how to approach treatment, and use your kidney failure risk equation to help your patients. Thank you guys for your time.